First, you know that light, human eye can see some spectrum of light, not everything that is available in nature, but some spectrum between 400 and 700 nanometers. Longer than 700 are microwaves and radio waves, and shorter waves than 400 are ultraviolet, X-rays, and gamma rays. So this is the visible spectrum of light. And what life is has really kept the attention of scientists for centuries, and they have reached the conclusion that that light has both qualities of a wave and of a particle. So there are wave theories proving light has some wave qualities, like interference, diffraction, reflection, and refraction. And the corpuscular theory explains some phenomena like dispersion, radiation, and absorption. Nowadays, we know light has dual nature. It behaves both as a wave and a particle. Here are some representatives of the wave theory, and what light resembles a wave is that it has also it has electric field and one magnetic field perpendicular to it, which fluctuates with the electric field. And as a wave, it has its length, amplitude, and frequency. And here are phenomena like interference. If two waves that have equal amplitude in initial phase, they overlap, then a new resultant wave appears twice as big as an amplitude, then it's called constructive interference. And if two waves with equal amplitude but opposite initial phase have destructive interference, so they neutralize each other. One experiment of interference was performed by Jung. He made this experiment with light waves originating from one light source with equal amplitude and in phase. And when they pass through two slits, resultant is a wave of equal amplitude but out of phase. And as they interfere on a screen, white and dark strips alternate as a result from this constructive and destructive interference. Wave theory also explains diffraction of light. It means diffraction refers to various phenomena that occur when a wave encounters an obstacle or a slit. It is defined as the bending of light around the corners of an obstacle or aperture into the region of geometrical shadow of the obstacle, that by definition. What that means in our human eye, we'll see later on in the lecture. So one of the great supporters of the other theory of light, corpuscular theory, is actually Isaac Newton, although Pierre Gassendi was the first one to publish it was actually published after his death, but he first created a theory about light being a particle. And Isaac Newton was actually a great supporter of this theory. And as a proof of this, he points the linear propagation of light in homogeneous media while waves refract and reflect. So unlike waves, light has this quality of a particle, have this linear propagation in homogeneous media. So Newton made this experiment to dissociate the white light beam into colors using two prisms. So he dissociated the light into colors and then again turn this dissociated colored light into white using a second prism. So that's about the two theories of the dual nature of light. What about our human eye? It is an optical system, and we can make this parallel with the optical system of a camera. You see the aperture being the pupil, the lens being the lens of a camera, the diaphragm of the camera being the iris, the film being the retina, and the black paint the choroid. Actually, the eye, human eye, is a complex optical system composed of several refraction media and several refraction surfaces. And the end refraction effect of the total optical system depends on two constants: index of refraction of the medium, radius of the curves, and the distance between these surfaces. So, what are the main refraction media and surfaces? So, cornea is the main refraction media and surface. It has this, and we know the index of refraction. The refraction depends on the index of refraction, the radius, and the distance between the surfaces. So the average refraction power of cornea is 43 diopters. It is the main, it has the high index of refraction because cornea is situated in between two absolutely different quality of media, like the air and the anterior chamber liquid. So the index of refraction is high, and cornea has the higher refraction power. Average 43 diopters. It can be steeper, like having 46 diopters, or cornea can be flatter in some eyes. For example, index of refraction 39 diopters. But the average refraction power of this main refraction structure of the eye is 43 diopters, and it is cornea. Lens is another refraction structure. It has these parameters here, and the importance is that refraction power of lens in quiet state is about 19 diopters. And what is accommodation? We'll see in details later on in the lecture, but with the contraction of ciliary muscle and the syn zonally loose, the lens can become flatter and refract more, up to 33 diopters. And actually, this is a mechanism for clear vision at different distances, not only at distance but at near. So, clear vision at near is performed by the process of accommodation, and refraction power of lenses changeable. So without accommodation, it is about 19, and with the participation of accommodation up to 33 diopters. Other refraction media are with less of importance, but they are still part of this refraction structure of the eye. They have nearly one and the same index of refraction. You see that's anterior chamber, liquid, and vitreous. They are also part of the refraction structure. We mentioned that the diaphragm of the camera is compared to the pupil in the human eye. And what's the importance of the pupil? It regulates the quantity of light that enters the eye. So you see very, very small pupil is when there is a bright light, and this is some photoprotection of the retina. And very pupil dilate when it's dark outside to let more light into the eye. These two pupil is governed by a parasympathetic vegetative nervous system. So with sympathetic and parasympathicus. Parasympathicus is along the oculomotor nerve, and it innervates, ciliary muscle and sphincter pupillae. And dilator of the pupillae is with sympathetic innervation. So that's why when we have stress, we also can have dilation of the pupil. And when we accommodate, also the pupil can constrict because both muscles, ciliary muscle and sphincter pupillae, have both parasympathicus innervation. Some consider retina being another refraction structure because of its concave spherical surface, because light travels all the way through first cornea, anterior chamber, lens, vitreous, and you see travels all the 10 layers of retina to meet the photoreceptors, and then the impulse is created, and it travels along the visual pathway. So we have this best resolution of visual acuity in the very center of retina, which is called macula. And especially fovea centralis, where we have just one photoreceptor connected with one bipolar and one ganglion cell. All the inner layers in this area are pushed aside. So we are discussing something like physical qualities of the eye apparatus, and in order to study these parameters based on the examination and study of lots of examined eye, some schematic eyes models are created which represent one average ideal human eye. One of the most popular and useful is the Boustrand schematic eye, being a central optical system with homogeneous media, ideal spherical surfaces, and the focuses are points, two main points, H1 and 2 in the anterior chamber, two nodal points around the posterior surface of the lens, and two main focuses like points, situated accordingly 15 and 7 millimeters, and the posterior focus are 24.4 millimeters from the cornea. And as we said, because of these calculations of Kustrand schematic eye, we have these numbers, the average diopters of cornea 43, lens 19, anterior chamber refraction power. The average axis of the eye, so that's anterior posterior length, is about 24 millimeters, and the refraction power of Kustrand eye is calculated 58.64 diopters. For the purpose of creating images on the retina, even more simplified models have been created, like Donder's eye, with only one optical media, one refraction surface, only 2 points cardinal, one main, one nodal, two focuses, and the refraction power of Donder's eye calculated 66, 67 diopters. You see how easily a retinal image is built using this schematic model, because it uses one nodal point as a center through which the passing rays don't refract. So you can easily build a model. That's the formula of Kustrand schematic eye, which is mostly used. You see, according to this formula, the refraction power is 58.64 diopters. But thanks God, we are ophthalmologists and not physicians, and we are not interested how much, or we are partly interested in some cases only, not as far as refraction, like prescribing glasses. We don't calculate how much the dioptric power of cornea is, lens, and overall of the eye. We are interested as medical staff, we are interested in clinical refraction of the eye. So not exactly diopters of different structures, like absolute value, but we are interested in the position of the main focus in respect to the retina. And it depends mainly on two factors. First, if these parallel rays from eternity meet this refraction media and the focus it falls on the retina itself, we have normal refraction or Ametropia. And when the focus is outside the retina, we have Ametropia. I saw some Greek names among you, so there are Greek students, and this comes from Greek language, Ametropia. And when this focus is in front of the retina, so if the eye retina is here and the focus is in front of the retina, we have myopia. And if the eye here and the focus is behind the retina, we have hyperopia. So still, That is static clinical refraction without the partition of accommodation. And accommodation, as we mentioned, is a process to increase refraction so that the eye be able to see clearly at near distance. So, all these mathematical models are, they look at the eye as a centered structure, while nature is not symmetrical, it's not perfect, there is always some asymmetry, and human eye is not a centered optical structure. It has lots of imperfections. Here they are. We have spherical aberration, we have chromatic aberration, diffraction. I promised to see what diffraction in the eye can mean. Irradiation, astigmatisms of oblique incidence, Aniseikonia, and as we mentioned, Ametropia, when parallel rays from eternity don't fall on the retina to have a clear image on this very structure on the fovea, but in front or behind the retina, and so cornea cannot be a perfect sphere but voidal, so some astigmatisms may also take place as a refraction error. So we look at these imperfections shortly, and then we'll reach refraction errors. So what is spherical aberration? You see, the central and peripheral rays have different refractions, so that parallel rays are not focused in one point, but something like line, because parallel rays refract more than the centered, say, have longer focus here. And that's called spherical aberration. The eye has its compensation a little bit to compensate for this aberration, because cornea is flatter in the periphery, and peripheral parts of the retina have small index of refraction. If you see, go back to the indexes of lens, you'll see. And these two compensations can a little bit decrease this high refraction of the periphery of the lens. So a little compensation of this imperfection. What is chromatic aberration? Monochromatic rays refract with a different refractive power. So long red waves, they are long and refract less, and the focus is further away, behind. And the blue short waves, they refract more and are a little ahead of the red, and the others are in between. So this is chromatic aberration. Not a single focus, rather sum up of focal distances of different colors. So the compensation, natural compensation of this imperfection, is that lens and macular pigment absorb the blue rays and decrease this aberration. That's why, because blue rays are a little in front of the fovea, we can say myopic. That's why when we use this blue, you see this violetish colored blue protect anti-reflex, when we use these glasses, we have more contrast in the picture, just because they stop these blue rays, and this slight myopia becomes compensated. But the natural compensation a little bit is from lens and the macular pigment. What is diffraction? We said when a light comes from a very small opening, these circles around this opening appear, and it is what happens in the eye when we have a very small pupil. And this diffraction actually, these small circles around the opening that appear, they interfere with the clarity of vision. What is astigmatisms of oblique incidence? As we said, the optical system is not perfectly centered. So we have here a visual axis which connects some object with the fovea. And we have one line optical axis that is perpendicular to the iris plane. And you see they don't coincide. There is a small angle in between these two lines, which is called angle kappa. Normally, if we have a light source towards the eye, we see these foveal corneal reflexes. That's Hyperopia reflex. We'll speak about it in strabismus topic. They are not quite in the center of the eye, these reflexes, but a little nasally. So that's because of this angle kappa. They have to be symmetrical. If they are not symmetrical, so the illusion of strabismus or real strabismus might be the cause. We'll speak about this in another topic again. So irradiation, what is it? If you see this white square and black square, it seems that the white one is bigger than the black one. So this is the visual perception of 3D objects or 2D figures on a contrast background. And when the object seems bigger, we have positive irradiation, or when it looks smaller, we have negative irradiation. Actually, the two squares are equal in size, but you see that irradiation, which is the basis of visual illusions. What is Aniseikonia? So, in order for the binocular vision, each eye has an image, two images that are fused by the brain into single binocular vision, normal single binocular vision. In order for these two images to be fused by the brain, these two images have to be nearly equal in brightness. So we could have one very clear image and one absolutely not clear. They can't be fused into one. So, and if we have that big image and that small image, the brain also can't fuse these two images. And that is aniseikonia. Mostly it's because of refraction cause. For example, one eye has plus 7 diopters, the other plus 1. So if we prescribe these glasses, because we see hyperopia is corrected with plus lens, which makes bigger image, so the two size of two images will be quite incompatible for the brain to fuse them. So we can't really prescribe these glasses. We have to do some compromise. We can prescribe two pairs of glasses, one that can be worn every day, and second, with full correction of hyperopic for treatment of amblyopia with occlusion of the other eye. So the difference, like diopters between the two eyes, is at most 3 diopters to be tolerated, like glass wearer. Bigger than that, it's not tolerated because of aniseikonia. Contact lens correction can tolerate a little bigger difference than glass correction. Aniseikonia may be due to anatomical cause, the photoreceptors being with different densities in both eyes, but it's not so common. The most common cause is refraction difference. So we reach our main topic, Ametropia, when parallel ray eyes from eternity reach the refraction structures of the eye and the focus fall on the fovea. We have ametropia. And if that's not the case, we have ametropia. Ametropia can be refractive. If, for example, the cornea is not the average 43 diopters, but 46, it refracts more, and we have the focus in front of the retina like myopia. Or we have flatter cornea, 39, which refract less, and the focus will go behind the retina. We have hyperopia. Ametropia can be axial. So cornea might have normal average of 43 diopters, but we can have a longer anterior-posterior axis. So normal refraction but longer eye, focus will go in front of retina. Or normal refraction power but shorter eye, so the focus will come behind the retina. So you see where the focus will fall depends on two factors, refraction power of the medium and axial length. So they can be combined. Both refraction power and anterior-posterior axis are with normal average value, but incorrectly combined. Okay. So, as we said, we have hyperopia when parallel rays, when they meet the structures, refraction powers, the structures, focus falls behind the retina. Myopia when the focus is in front of retina. You see, myopic eye, we can have normal refraction of cornea, but longer eye, so the focus will fall in front of retina. So, here again, we have normal vision, normal refraction, the focus falls on the fovea. In hyperopia, the focus is behind the retina. So, what is accommodation? It's a dynamic process which increases the refraction power of the eye and the ability of clear vision at closer distances than the punctum remotum. What is punctum remotum? Punctum remotum is the most distant point of clear vision. In ametropic normal refraction, punctum remotum is 5 meters. Practically, theoretically, it is in eternity. So, eye with ametropia, with normal refraction, can see at distance without any problem. But when an ametropic eye tries to see it near, accommodation takes place. So, accommodation actually aims to always keep the image of the observed object focused on the retina, no matter of the distance. So it is an unconditional reflex, and the stimulus for accommodation is blurring of the image of the retina, and accommodation is switched on. And the clinical refraction with the participation of accommodation is called dynamic refraction. Unlike the static refraction, clinical refraction without the participation of accommodation. So any attempt of the eye to fixate at closer distance triggers accommodation. The closer the object, the bigger the tension of accommodation. So at one nearest distance, the object is no longer seen clearly, and it becomes even blurred and doubled. So this quite the point at which the eye is adjusted to see it near at maximum tension of accommodation is called near point of clear vision, punctum proximum. So accommodation is characterized by its area, which is the distance between punctum remotum and punctum proximum. The power of accommodation, the number of diopters in which the eye is able to increase the refraction of the from the state of relaxation to maximum accommodation. And resistance is the ability of ciliary muscle to maintain accommodation for a long time without fatigue. So these are the qualities of accommodation. So what is presbyopia? It is when, let's say, first, okay, so let's go back to hyperopia. We said in normal eye, Ametropic eye, the light the focus falls on the retina and a person can see normally a distance, but in order to accommodate, here at 33 centimeters, we have 3 diopters of accommodation. So it is calculated by the formula 1 divided into centimeters of work. It is 3 diopters of accommodation. Remember, reading distance, the ametropic eye accommodates 3 diopters. What about hyperopic eye? The distant point of clear vision is not in eternity, but it's behind the eye. And in order for the hyperopic eye to see clearly, because small children, babies are born with small eyes, okay? So 99%, if not, hyperopic, but not every child has glasses. That's because babies are born with one normal value of hyperopia, about 2.5, 3 diopters. And they can still see clearly, but unlike ametropic eye, in order to see a distance, they switch accommodation, okay, to make greater refraction of the lens, and they bring the focus on the retina. While ametropic eye can see a distance without accommodation, but hyperopic eye accommodate to see clearly a distance. And in order to see clearly at near, it has to accommodate still plus 3 diopters. So if an eye has 3 diopters of hyperopia for distance, here the eye has to accommodate 6 diopters. So hyperopic eye accommodates more than the ametropic eye. And if, for example, medical students have a test or some exams and a hyperopic student reads a lot, the result might be headache because of accommodative asthenopy. Even spasms of accommodation can occur in hyperopia spasmus that brings the focus in front of retina and can mimic myopia, but with headache. So we have later we'll see prescribed glasses only after cycloplegia if there is some spasms to be released, and then examine refraction. So what is presbyopia? Because hyperopic eyes accommodates more than ametropic. This exhaustion of accommodation with aging so gives this age-related weakness in every eye. I mean, children can really have strong accommodation, and with age, this power decreases. But first, weakness appears in hyperopic eyes that accommodate more than ametropic eye and even much more than myopic eye. And this weakness usually starts at the age of 45. These 3 diopters that the eye accommodates for NEA decompensate at the age of 60. So little by little, we put glasses for NEA at the age of 45 plus 1.5, at the age of 50 plus 2, 55 plus 2.5, and at 60 it all decompensates. That's only related to age, this presbyopia. So if the person has plus 2 for distance and is 50, he'll still have plus 2 for distance, but will have plus 4 for near. Or if we have, okay, we'll go back to presbyopia in myopic patient. Minus is myopic patient. If we have 50 years of a patient with minus 2, myopia of minus 2, at the age of 50, he still will have minus 2 for distance, but at near, he will not need glasses because minus 2 plus 2, they neutralize. And while all 50-year-old Ametropia Hyperop put on glasses at the age of 50, myopic patient will remove them. There are two main meridians. One is refracting most and the other least. They're always perpendicular to each other, and all the intermediate are in between them. And the point, the focus is not a point, but a rod. And actually, of the two main meridians, two rods at distance to each other. Astigmatismus eyes can't use accommodation in order to see clearly, like mechanism. We'll see types of astigmatismus. Now there is, as we said, not perfect symmetry in nature. So there is one physiological astigmatismus rectus up to 1 diopter is compensated by inversus astigmatismus of the lens. So there is some type of physiological astigmatismus, but as a whole, it can't be compensated by the eye and needs correction. Here is one schema, the so-called conoid of Sturm, that really illustrates this picture. That's cornea. It's not a sphere, it's ovoidal. This meridian refracts different from this, from that. But these are the two main meridians, okay? The red one refracting here, and the blue, red refracting more, and the blue least here. So these are the two focuses that are not rods, but they are not point, but rods, and at some distance to each other. These two main meridians are always perpendicular to each other. All the other meridians of the cornea are in between the two main meridians. So regular astigmatismus is when, this meridian has this refraction power all along the cornea. Usually, irregular astigmatism is when there are some scars or some pathology on the cornea that along the way of one meridian, the refraction is different. So we have rectus astigmatismus when the vertical meridian refracts more than the horizontal, like here, or if it's vice versa, when the horizontal meridian refracts more, we have inversus astigmatismus. The two main meridians are always perpendicular to each other, but they cannot be exactly 1.80 and 90 degrees. They can be obliquely. For example, at 30 and 120, or at 45 and 135, always perpendicular to each other, but they can be obliquous. And when one of the meridian is ametropic, we have astigmatismus simplex. When both meridians are either myopic or hyperopic, we have astigmatismus compositus. And if one meridian is myopic and the other is ametropic, we have mixtus. Here is one very easy schema in order to remember what I just said. So when you have both hyperopic or myopic compositors, when one is ametropic simplex and one is hyperopic, the other myopic, we have astigmatismus mixtus. So here are the two main meridians. If in retina 1 case, both are behind the retina, both are hyperopic. If retina is here and one focus is on the retina and the other is behind the retina, we have here this situation if we have simplex. If retina is here, one is in front of the retina, is myopic, the other is behind the retina, myopic and hyperopic. If in retina 4 case, one is on the retina and the other is in front of the retina, we have one ametropic, one myopic, and in retina 5 case, both are myopic. So how can we, what we pay attention on is when vertical refracts more, we have astigmatismus rectus, and when the horizontal refracts more, we have astigmatismus inversus. Once I was trying to explain what does more refraction mean, it is actually myopic refraction is highly refractive, hyperopic is less refractive. And I was trying to explain the students and I couldn't see understanding in their eyes. It's such a pity that we can not see each other in the eyes while I'm explaining it to see the feedback. So this online education really can't let us in closer contact. But one of the students said, okay, he helped me explain it actually to the others. So if that's 0, ametropic, and here is plus hyperopic, and this is minus, the refraction power goes from less plus and more minus. So if it goes less plus and more minus, refracts more. And how do we give the full diagnosis of the type of astigmatism? So how do you think? First, we consider which refracts more, vertical or the horizontal meridian. So what we have here is a result of our skiascopy or retinoscopy. We see in a moment what it means, but let's take it as a ready result. We have vertical +2 and horizontal +4. Which meridian refracts more, vertical or horizontal? How do you think? Hello? Are you there?
It's horizontal.
We said less plus refracts more, less plus and more minus. So vertical refracts more because it's less plus. So it is rectus. Then both are with plus plus. So hash hash, HH, it is compositus and it is hyperopicus. So this astigmatismus is rectus, compositus, hyperopicus. What about this one? Which refracts more, vertical or horizontal?
Horizontal.
That's right, because it's more minus. So it is inversus, because both are one minus minus, it is compositus, myopicus. So this is astigmatismus inversus compositus myopicus. What about this one? Which refracts more?
Horizontal.
Horizontal. So it is astigmatismus, and because it's plus minus, it is mixtus. So inversus mixtus. Here you are. So you see how complicated diagnosis it seems like, but it's not so difficult finally. But that's the full name and the full explanation of the astigmatisms. Let's do some more. Here, rectus or inversus, the first one. The refraction power goes from less plus to more minus. So here, which refracts more?
Rectus.
That's right. Vertical refracts more, it is rectus. Then one is ametropic. So what is it? Which type? Compositus simplex? Sorry?
Rectus presbyopic, if I'm saying correctly.
So it is a rectus. It is also simplex, because when one of the meridian is ametropic, it's called simplex, and the other is plus hyperopicus. So it is rectus, simplex, hyperopicus. What about this one? Which refracts more? Rectus or inversus? Zus is the next, this one. Which refracts more?
Vertical.
Vertical, so it is rectus. It is again simplex because the other is ametropic, and it is myopicus. So rectus, simplex, myopicus. What about this one? Which refracts more?
The horizontal?
That's right. That's why it is inversus, simplex, myopicus. So, how do we examine refraction? So what I mentioned is we do clinical refraction. We are not doing physical refraction. We can measure the corneal two main meridians in cornea as the numbers of diopters only to calculate intraocular lens. But as far as checking and correcting the refraction, we are interested in clinical refraction, not how much the cornea and the whole eye refract as diopters, but where the focus falls on the retina. So you had already a lecture about visual acuity, right?
Yeah.
Yeah, so after 5 minutes after you check visual acuity, you already know, using subjective method of examination of refraction, whether the patient is ametropic, hyperopic, myopic, has astigmatisms, or has some disease of the eye. So using this trial lens box and using the visual chart and the glasses here. How do we do that? So here you see the trial lens box here. Let me see if I have something. Okay, let's do here first, have a look. So hyperopia is corrected by plus glasses. They are convex plus lenses. They bring the focus forward to put the focus on the retina. So myopic lenses, myopic eyes are corrected by biconcave minus lenses. They bring the focus backwards. And in astigmatismus, usually we correct one of the meridians with spherical lens, plus or minus, and the other main meridian we further correct using cylindrical lens. That means cylindrical lens corrects only the meridian perpendicular to the axis of the cylinder. So here let's go back to our lens box. Here on both sides are plus lenses to correct hyperopia. Here are minus lenses, biconcave, They are from 0.25 to minus 20, respectively plus. These here are cylindrical lenses. They can be plus and minus. They have one here, okay, like mark to mark the axis of the cylinder, and they don't correct all the meridians like spherical lenses. If you put spherical lens in front of the eye, plus or minus, all meridians of the corneas are corrected. While cylindrical lens, if you put this mark, it corrects the meridian perpendicular to the mark. So we have cylindrical plus or minus lenses in this trial lens box. So how do we do subjective method of examination? First, monocularly, we check visual acuity. So if visual acuity is 1, so it's normal, we can ask a question, what the refraction of this eye can be? Who can see clearly at distance? Who? Ametropic eye, right? Are you agree?
Yes.
Yes.
Yes, because ametropic eye can see clearly at distance without accommodation. But who else can see clearly at distance accommodating, using accommodation? Hyperopic eye, right? That's why we mentioned babies, not all children has to wear glasses if they can't accommodate and see clearly. They are all hyperopic, but only some of them need glasses. That hyperopia is bigger than the normal value. So, and they can't compensate through accommodation. So if the eye sees normally, it can be ametropic or hyperopic. So in order to decide what of the two, we put plus 0.5 glass. And if the eye is ametropic, so focus is here, and we put this lens, will it make it go the focus forward and make him myopic. Okay, because it goes from here to here, from back forward, the focus of hyperopic eye, that is behind the eye, through accommodation or plus lens, it goes forward to fall on the retina. So if we put plus 1 and the eye is ametropic, we'll make it myopic and the patient will say, now it's worse. Okay, so we decide that's ametropic eye. But if the patient says, well, it's fine, so that means we moved it from here. Then we put next glass from here, still good. Then we put next one, still good. Can see quite well. Then next glass, it becomes worse because the focus comes in front of the retina. So the patient takes glasses here from this trial box. Next glasses like plus 0.5, then plus 1, plus 125, plus 1.5, and then 1 plus 47, it becomes worse. Then the higher plus that the patient still sees clearly defines his hyperopia. So that's how we differentiate between ametropia and hyperopia in case the patient sees clearly normal visual acuity on examination of visual acuity. But what if the patient can't see 100%, but for example 0.6? What the possibilities here? Can it be myopic, hyperopic first? Can it be hyperopic? How do you think?
What do you mean that it is 0.6?
Visual acuity, vision. not 1, but 0.6, something in the middle of the chart. He can see is up to here and can't see more. So we have to decide what through subjective method, whether it is refraction error or it is a disease, or what refraction error we can expect, what refraction error. Can he be or she ametropic? Can the patient be myopic, hyperopic, or he has astigmatisms?
I think myopic, right?
So, can he be hyperopic first? Hyperopic. Yes, because accommodation can compensate some hyperopia, but there are some severe hyperopia, for example, 5 diopters. Patient accommodates, but still can't bring the focus on the retina, so it can be hyperopic. Or aging hyperope that can't compensate not only for near, but for distance as well, because of weakness of accommodation. So when he was younger, he could see clearly at distance, but then first at near, then he can't see at distance as well because of weakness of accommodation with aging. Because in order to see clearly, the hyperope has to accommodate both for distance and for near. So he can be, in this case, hyperopic. He can be myopic, most probably, right? But he can have also astigmatisms, or the decrease of vision is not due to refraction error, but some disease of macula, which is the anatomical substrate of form vision, actually. So we have to exclude all these 4 possibilities. We again start with plus lenses, plus. From 0.6, from this line, he becomes here, next plus here, next plus here. It also normal, but he can take 1 more glass before it becomes worse. So still the higher plus gives the value of the hyperopia. But if we add plus half diopter and it becomes even worse, this line, then we switch to minus lenses. And what happens when we add minus lenses? In myopia, the focus is in front of retina. For example, we add minus 0.5 and we get vision a little better. For example, 0.7, 0.8. At minus 1 diopters, we have vision, okay, clear vision of 1. And what if we put next minus, for example, minus 1.5? The focus will become behind the retina. He will switch accommodation and still see clearly. So the higher plus we set, but the smaller minus that can correct speaks about myopia. Higher plus, smaller minus. So third case, we try with plus, no improvement. We try with minus, no improvement of vision. Then 2 more possibilities, either astigmatisms or a disease of the eye. So one very easy method to differentiate between the 2. There is one stenopaque hole. It's like this occluder, but with small opening here in the middle. So if you place this stenopaque hole and you have astigmatismus, the picture becomes clear because all these peripheral, different meridian, different focuses is bypassed because only the central ray is reaches the eye, and the vision becomes clear, and the patient says, "Oh, how nice! I want these glasses." You have to prescribe these beautiful glasses for him to see so well. But if the decrease of vision is because of impairment, some disease of macula, which is the main substrate of the eye, then placing distant opaque hole, the patient might see better using paramacular retina, but if you put this point, the vision will become worse. So you differentiate between, is there astigmatismus? No, not astigmatismus. I have to see here for some pathology of macula. That's only subjective method of examination. That means to quickly, just for less than 5 minutes after taking vision, you get an idea about is this eye hyperopic, myopic, astigmatismus, or a disease. You rarely prescribe glasses only on this objective method. Maybe in some hyperopia adult patient with hyperopia and presbyopia, you can prescribe glasses only by subjective method. What you do actually in clinical practice is objective method of examination of refraction, retinoscopy. In some textbooks we call it skiascopy, but it's one and the same. So what is the idea behind retinoscopy? First of all, we have to make cycloplegia, so to paralyze the ciliary muscle. And then, because distant point of clear vision of ametropic eyes in eternity, in hyperopic eyes, virtual behind the retina, in myopic it's something closer than in the ametropic. So one standard situation is created to bring the distant point of examined eye at 1 meter, which is distant point of clear vision of myopic eye with -1 diopter, using these scales, plus and minus lenses. After cycloplegia, after you paralyze the ciliary muscle, so you have dilation of the pupil secondarily because sphincter pupillae is also paralyzed. And using this skiascope, when you bring light to the fundus, the reflected rays are red. We get the red reflex because of the vascularized choroid. And when we move this shadow, when we move the skiascope, we have one shadow appearing because part of the rays that are reflected are stopped by the periphery of the iris, and when moved, one shadow appears that moves either in the same direction or in the opposite direction. So you move the skiascope here and the shadow to the other way. In the same direction with movements, you move here and the shadow moves same direction. You can do this on one horizontal and a vertical meridian. And if we have with movement of the shadow, we use plus scale. And if we have against movement, we use minus scale until we neutralize this shadow. Neutralization means the way the shadow moves with the movement of the skiascope. One of the sudden, it just breaks from the middle. And next glass, you use these are like in the trial frame, okay, minus plus 1, minus or plus 0.51, 1.52, 2.54, okay? You just give more and more glasses until neutralization. That means neither in the same nor in the against the direction, but splitting from the middle. And when you put next glass, you become inverted, okay? So you use the splitting of this shadow. What I wrote here, so I examined horizontal use plus, 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 and I here neutralize in plus 5, and I wrote plus 4 because I added minus 1 because the examination is at 1 meter, and we bring the distant point of clear vision at 1 meter, which is in myopia of minus 1, this standard situation, and we correct it by adding minus 1. So then I do this movement on the vertical, and I here neutralizes plus 3, I write plus 2. I always add minus 1, and that's the result of my skiascopy. Let's do...
Professor, can you explain one more time why you add that at minus 1?
Because I bring the distant point of clear vision using these scales at 1 meter. The distance, can you see? The distance is 1 meter. At the neutralization, I neutralize 1 meter is the distant point of clear vision of myopic eye of minus 1. And we create this standard situation because we can't examine distant point of all the eyes, because distant point of Ametropic eye is something in eternity, of Hyperopia behind the retina. So this standard situation is created to bring the distant point of examined eye at 1 meter, which is the distant point of myopia of minus 1. So we have to recalculate for the eye examined by adding minus 1. Okay? For example, so here, when you have with the same movement, you take plus scale, okay? So you see, you have here plus scale, and you neutralize at plus 3, I add minus 1, and I wrote plus 2. Here I had also with moving shadow, and I neutralized at plus 1, minus 1, I wrote Ametropia. After I recalculate, add minus 1 to both meridians. So here what is, for example, here minus 1? I have written minus 1. When we have minus 1, when I'm in the distant point of clear vision and I try to do skiascopy, I neither get in the same direction nor in the opposite, but I get splitting of the shadow. So I'm in the distant point of clear vision and I write minus 1 without using the scales, okay? So what you have to remember is you use the plus scale neutralizing hyperopia. So if you have in the same movement and you neutralize it with plus half diopter, with the same, and you neutralize it with plus half 0.5, what the resultant will be on your skiascopic result? Plus 0.5, minus 1, minus 0.5. You always add minus 1. So with plus scale, you neutralize hyperopia. Ametropia, when you neutralize with plus 1, minus 1, it's ametropia. And myopia up to 1 diopter. When you have myopia of minus 1, you don't use the scales because you're in the distant point and you have this splitting of the shadow. And only in myopia of more than 1 diopter, you use the minus scale. Why do you get this against movement? Okay, imagine, because the distant point of clear vision of myopia of more than 1 diopter is between the eyes of the examiner and the examined. So they cross, and when you move the shadow, you get the against movement. So against movement, you also you have only myopia of more than 1 diopter, and you use this minus scale. You again add to -1. For example, if you neutralize vertical at -2, you write -3. You add -1. If you neutralize at -5, you add -1 and you get -6. Okay? So that's the skiascopic objective method of skiascopy, and you can then do correction according to your result. Of course, that's the retinoscopy. We have automated refractometry that use infrared rays and can give the result here, right and left eye. It's given -3 sphere, -2 cylinder, and the axis of the cylinder, and left eye -3, -1, and 0.76. It's very easy to use automatic refractometry, but we still use cycloplegia, because otherwise the patient accommodates and might hide, especially the plus diopters. But in children, small children, especially with with strabismus, with squinting, we do retinoscopy is compulsory. We can't rely only on this computer testing. So correction of ametropia can be optical with glasses and contact lenses, and we already mentioned what type of glasses we use to correct hyperopia, myopia, and how do we correct astigmatisms using spherical lens to make one of the meridian ametropic, and then cylindrical lens to further correct the other meridian, placing the axis of the cylinder perpendicular to the meridian we want to correct. And we also can correct ametropia with contact lenses. The standard, for example, of myopia, to use contact lenses, the age of about 15, because wearing contact lenses is very responsible for a good skill and good hygiene, because it can be with very severe complication if some fungi or bacterial keratitis. So we'll see in next lectures what clinical picture of these severe diseases, and can be really provoked by not good hygiene or not good manipulation with contact lenses. There are lots of surgical corrections of ametropia, like using photorefractive keratectomy, this LASIK and LASIK for myopia. What's the difference? The first procedure was to remove epithelial and then use excimer laser to evaporate part of the stroma to become flatter cornea, thus to correct myopia, but it was very painful. It needed 24 hours of real pain for the revitalization to take place. Then, without removing the epithelial, such you see flap inside the cornea. That's one flap was removed, and then laser is performed, and then you bring back the flap, so this pain is avoided. If you have excessive myopia of -10, you can correct it if you just remove the lens. A phakic eye, when you remove the lens, the correction is +10 diopters in glasses, and so on -10 you can remove clear lens without having cataract for refraction purposes. Or do iris clip implant in front of a clear cornea. You put implant for correction, so it's surgical correction of ametropia. Or so you can also have posterior chamber implants, so some implants like we do in cataract, removing of opaque lens, but here in clear lens for the purpose of correction. Mostly, so patients for candidates for laser correction of myopia are more often. They have better results when they have myopia about -5, -6, 100% real guarantee. When you have -10, you have to measure how thick the cornea is because you don't have to make it so thin to be risky by evaporating too much stroma. So some topography of cornea precedes this manipulation, and you might decrease some of the diopters, but can't really compensate all. Of course, like all surgical procedures, some complication might take place. So when a myope of -2 asks me whether what's my opinion about surgical correction of this myopia, it is okay. The answer is all eye doctors wear their glasses, so -2 is not some diopters that require surgery, okay? And at the age of 50, this -2 will read without glasses. And if they do surgery, refraction surgery have to be done after the growth of the child has finished, for example, 2020. So otherwise myopia might change, so not in child age and not too late. So if around 25-30, so that would be happy at least 15-20 years without glasses. Otherwise, if you're 40 and decide to do surgery, then presbyopia will bring you back to glasses. Nowadays, lots of correction of also contact lenses, presbyopic, like multifocal, to avoid glasses, are also available. So lots of types of correction you can have of refraction error, but the most classical are glasses and contact lenses. So accommodation, we mentioned what it is, but there could be some impairment of accommodation, like spasms of accommodation. Most often, what is spasms? Who accommodates most? Hyperopic. And in real hard work at near, what happens is spasms of accommodation might mimic myopia. So all of a sudden, the patient can't see a distance. And for example, medical student and has a headache. It's not normal for myopia to appear after the end of growth. So school myopia starts at teenage, and while the child grows, okay, it can further increase the diopters. With aging, hyperopia decreases, lots of kids become ametropic, some go to myopia, and myopia can increase until the end of the growth. Okay. So it's not normal for a 25-year-old to become myopic. So what you do is cycloplegia, because if you do only subjective method of accommodation, he will correct with minus lens, but it's pseudomyopia because of the spasms. The patient suffers from headache. So when you do cycloplegia and relieve these spasms, it's actually the treatment. And you can give some plus glasses, maybe only for reading from near distance, in order to avoid further spasms of accommodation. So young hyperopes are most commonly can do this spasms through abnormally excessive accommodation, and some medication also can give spasms of accommodation. This pilocarpine is anti-glaucoma's drug, collyrium, okay, that can really give this complication. Paralysis of accommodation is full absence of accommodation, usually because of parasympathicus damage. You can have weakness of accommodation or instability. People can easily become tired, can't really read for a long time. Lots of factors might cause this impairment of accommodation. Okay.